Today let's study the lung volumes and capacities. Capacity is the measure of two or more physiological volumes, and we have 4 volumes and 4 capacities. First, let's see tidal volume. Tidal volume means the amount of air that we breathe in during quiet inspiration, and it also refers to expiration, that is the amount of air we breathe out during quiet expiration. It measures about 500 milliliter. Next, we have inspiratory reserve volume, that is it's the air that we can breathe in even after the normal inspiration, that is the air that can be still breathed in even after normal inspiration. And next we have expiratory reserve volume. This is the air that we can still breathe out even after the normal expiration. And next we have residual volume. This is the volume that we cannot breathe out even after forceful expiration, that is air in the lung after maximal expiration. And this residual volume cannot be measured by spirometry, and also the lung capacities, which includes the residual volume, cannot be measured by spirometry. Next we have inspiratory capacity. This is the amount of air we can breathe in after the exhalation, that is it includes tidal volume and the inspiratory reserve volume, that is total volume of air we can breathe in. Next we have functional residual capacity. We have functional residual capacity. This is the amount of air that is left in the lung after normal expiration, that is after normal expiration we breathe out the tidal volume, and the amount of air that is left in the lung, which includes expiratory reserve volume and the residual volume. Residual volume is the volume that we cannot measure by spirometry, and it is the volume left even after maximal expiration. And residual volume along with the expiratory reserve volume makes the functional residual capacity. Now we have vital capacity. It is the maximum volume of air that is left after forceful expiration and forceful inspiration. This includes inspiratory reserve volume and expiratory reserve volume and the tidal volume. Inspiratory reserve volume means the amount of air we can breathe in after normal inspiration, and the expiratory reserve volume is the normal air, the amount of air which can be breathed out after forceful expiration. And tidal volume, we know it's the amount of air which we breathe in or breathe out during quiet respiration. And next we have total lung capacity. This includes total volume of the body, that is inspiratory reserve volume, the tidal volume, and the expiratory reserve volume, and the residual volume. The volume of air that is present in the lungs after the maximal inspiration. This is called the total lung capacity. Let's see the graph. As we discussed, tidal volume means the amount of air which we breathe in and breathe out during quiet respiration. And the inspiratory reserve volume is the amount of air which we breathe in forcefully after the normal or quiet respiration. And the expiratory reserve volume is the amount of air which we forcefully expire after the quiet respiration. And next we have functional residual volume. This is the amount of air that is left in the lung after normal, that is quiet expiration. That is after quiet expiration, the amount of air left. This includes expiratory reserve volume and the residual volume. And vital capacity, this is the amount of air except the residual volume. It includes inspiratory reserve volume, tidal volume, and the expiratory reserve volume. And then we have total lung capacity. This includes residual volume, expiratory reserve volume, tidal volume, and the inspiratory reserve volume. total lung capacity equals to 6 liter. And the amount of air we breathe in during quiet respiration is of about 500 milliliter, and that is from 2.2 liters. The fractional residual volume includes 2.2 liters during normal quiet respiration, and the air we breathe in makes about 2.7 liter during quiet respiration. And muscles which involved during quiet respiration is, during inspiration diaphragm is the main muscle, and during expiration this is passive, no muscles are involved. Now let's see pressures within the lung. This is the lung, and we have alveoli, and surrounding the lung we have pleura, we have visceral pleura and the parietal pleura. The visceral pleura, that is the inner layer that covers the lungs, and the parietal pleura, which is the outer layer which attaches to the chest wall. This is the chest wall, and we have ribs and the muscle. And the pressure within the alveoli is called intraalveolar pressure, and the pressure within the pleural cavity is called intrapleural pressure, and the pressure outside the chest wall is the atmospheric pressure. It is about 0 mmHg, that is 760 mmHg. Now let's see some of the other pressures. This is the alveoli, one of the alveoli, and this is the pleura. This is visceral pleura and the parietal pleura, and then we have thoracic cavity. And the pressure which is in between the alveoli and the pleural cavity is called the transpulmonary pressure, and the pressure which is in between the pleural cavity and the atmosphere is called the transthoracic pressure, and the pressure all the way from alveoli to the atmosphere is called the transrespiratory pressure. Here transpulmonary pressure is important, the pressure which is between the alveoli and the pleural space. Now let's study elastic recoil compliance. Elastic recoil means it's the tendency of any substance to collapse. It can be inward or outward. If we take an example of elastic band, its elastic recoiling, that is collapsing pressure, will be more. And if we take a thick rubber and the thin rubber, the elastic recoiling pressure, that is collapsing pressure of the thick rubber, will be more, and the collapsing pressure of the thin rubber will be less. If this is the thick rubber and this is the thin rubber, the collapsing pressure, inward pressure, collapsing pressure of this thick rubber will be more, and the collapsing pressure of thin rubber will be less. Next we have compliance. Compliance means it is a measurement of stretchability. If we take the same example, the thick rubber has less compliance because it cannot be stretched more. But if we take the small rubber, it can be stretched out more. Hence compliance of the thin rubber is more and the compliance of thick rubber is less. Let's apply this concept with the lung. The collapsing tendency of the lung will be more because since it is made up of elastic tissue, collagen, and the surface tension will be more in the lung. And chest wall, the collapsing tendency of the chest wall will be less because it is made up of ribs and the other muscles. So the tendency of the lung to collapse inward will be more than compared to chest. And compliance is measured by change in volume to the change in pressure. So the compliance of the lung will be less, that is the recoiling tendency of the lung will be more. Let's take the chest wall alone. Since chest wall is made up of ribs and other muscles, the collapsing tendency of the chest wall will be less. That is, chest wall tends to stretch out. If we take the chest wall and the lung together, the collapsing tendency of the lung will be inward and the collapsing tendency of the or compliance of the chest wall will be outward. So between these lung and the chest wall we have a visceral pleura and the parietal pleura. Hence this pleural, as we know, visceral pleura is connected to lung tissue and the parietal pleura is connected to the chest wall. Hence between these two layers there will be negative pressure. Since chest wall is pulling the parietal pleura outward and the lung is pulling the visceral pleura inward, there creates a negative pressure between these pleural space. Hence this builds up a negative pressure within the pleural space. That is, inward pulling of the lung and outward pulling of the chest wall creates a negative pressure between the pleural space. During inhalation, as diaphragm contracts, the chest wall will move outward and this chest wall will take the pleural layers outward. But the tendency of this pleural layers on the lung is to collapse inward. But we are taking the pleural layers and the alveoli against their will. So this creates even more negative pressure within the pleural space. That is, there will be negative pressure within the alveoli and the negative pressure within the pleural space. This negative pressure is important because, as we know, air moves from higher pressure to lower pressure. Since atmospheric pressure is 0 and pressure within the alveoli is -1, so air within the atmosphere will flow inside the alveoli. Hence during inhalation, due to contraction of the diaphragm, this creates more negative pressure within the pleural space and even in the alveoli. Hence air from the atmosphere will flow inside the alveoli, and this continues, and at the end of the inhalation the contraction of the diaphragm stops. As we discussed, the collapsing pressure of the lung inward and the expanding pressure of the chest wall outward creates a negative suction pressure of about -5 centimeter of water. This is enough for initiating the respiration. As we discussed earlier, due to collapsing pressure of the lung and the expansion pressure of the chest wall creates a negative pressure within the pleural cavity. This negative pressure of 5 centimeter of water is enough for beginning of the inspiration, and this -5 centimeter of water is enough to hold the lungs open to their resting level. And during normal respiration, due to expansion of the chest wall, this pulls the lung outward and creates even more negative pressure of about -6.5 centimeters of water. As we can see here, due to expansion of chest wall more during normal inspiration, this creates even more negative pressure within the pleural space. And after the end of the inspiration, the contraction of the diaphragm will be ended, hence the inflowing of the air will also be stopped. As we discussed earlier, alveolar pressure is the pressure within the alveoli. As we can see here, pressure within the alveoli is 0. When the glottis is open, the air will not flow. That is, the pressure in all parts of the respiratory tree will be equal to atmospheric pressure, that is about 0 centimeter of water. For the air to move in, that is for the air to move in during inspiration, the pressure in the alveoli should fall below the atmospheric pressure, from 0 to -1, because air will always flow from higher pressure to lower pressure. Hence alveolar pressure should fall from 0 to -1 centimeter of water. This happens because of the expansion of the chest wall and the contraction of the diaphragm. Next we have exhalation. For air to move out of the lungs, the pressure within the alveoli should be more, because air always moves from higher pressure to lower pressure. Hence at the end of inspiration, the contraction of the diaphragm stops. Hence this causes inward movement of the chest wall. This creates less negative pressure within the pleural space, and also positive pressure within the alveoli. Hence air flow out of the alveoli. That is, as we already discussed, due to collapsing of the lung and expansion of the chest wall, there will be a negative 5 centimeter of water pressure within the pleural cavity. This is enough to begin the normal inspiration, and during the normal inspiration, expansion of the chest wall will pull the lungs outward, and this creates even more negative pressure of about -8 centimeter of water. Next we have alveolar pressure. This is the pressure of air inside the lung alveoli. This is of about -0 centimeter of water, and for air to come in the alveoli, there should be negative pressure, because air flows from higher pressure to lower pressure. As we know, atmospheric pressure is about 0 centimeter of water. For the air to come in the alveoli, alveolar pressure should be negative. So during normal inspiration, the alveolar pressure will be negative. Hence during inspiration, the volume in the lung will increase. Hence that is the tidal volume, that is of about 0.5 liter. And during expiration, from -8 centimeter of water, this goes to of about -5 centimeter of water, and the alveolar pressure will increase, because air always move from higher pressure to lower pressure. Hence there will be positive pressure in the alveoli during expiration. Hence the volume in the alveoli will decrease. This is the normal inspiration and expiration graph. Let's study this graph in detail. This is the transpulmonary static pressure. Transpulmonary pressure is the pressure between alveoli and the pleural space, and we have the volume. When lung is resting, lung will be resting at FRC, that is functional residual capacity. Functional capacity, residual capacity includes expiratory reserve volume and the residual volume. And when during normal inspiration, we breathe in the tidal volume and we breathe out the tidal volume. This creates a hysteresis. And if we further increase the pressure, lung can only expand until it reaches the total lung capacity, that is of about 6 liters. And if we decrease the pressure, we can only breathe out, or lung will stop at the residual volume, that is of about 1.3 liters, 1.2 liters. Lung will be resting at FRC, that is functional residual capacity. Here airway and the alveolar pressure will be equal to atmospheric pressure, and the barometric pressure will be 0. And as we know, due to expansion of the chest wall, there will be slight negative suction. This is the intrapleural pressure, and the intrapleural pressure will be negative. And the inward pulling of the lung will be balanced by the outward pulling of the chest wall. We have discussed this. And the system pressure is atmospheric. We have compliance. We have discussed this. Compliance is the measurement of stretchability. It is the change in volume to the change in pressure. And compliance is inversely proportional to wall stiffness. That is, if we take the rubber which is thick, it will have the less compliance, and if we take the rubber or elastic which is thin, it will have the more compliance. That is, compliance is inversely proportional to wall stiffness. If wall stiffness is more, compliance will be less. If wall stiffness is less, compliance will be more, and the compliance will be increased by surfactant. And when there is increased compliance, lung will be easier to fill, as we can see in emphysema and older adults. And when there is decrease in compliance, lung will be difficult to fill because they will not be expanding, so it will become difficult to fill. This can be seen in pulmonary fibrosis, pneumonia, ARDS, and the pulmonary edema condition. We will discuss this ichthyosis in further videos.